Welcome to our U.S. Neuropathy Center's Informed Consent PowerPoint. The purpose of this PowerPoint is to give you an informed consent about your planned surgical procedures. By this point, you probably have a pretty good understanding of what we have planned for you from a treatment plan standpoint, but we want to make sure that we go through everything one more time just to make sure that you have the best possible outcome. Patients who are highly educated about their surgical process usually have better outcomes than those patients who are not fully educated. The goals of this presentation are simple. We want to give you a better understanding of the risks and benefits that are associated with the peripheral nerve surgery that has been planned for you and the types of surgery that we perform. We want to ensure that you communicate fully with us and our staff to assure that you're completely educated about the procedures which have been planned for you. We want to help you understand some basic nerve physiology and give you an understanding of what you are experiencing during the postoperative phase of your treatment. Also, we want to provide an opportunity to make sure that you are completely informed and have had an informed consent about your surgery. Some of the following sections may not specifically apply to your situation, and they may conflict with what your treatment plan is. In this case, always defer to your surgeon's instructions and what we have laid out specifically for you. The goals of any surgery, and especially those of peripheral nerve surgery, are to improve the patient's quality of life and function, to decrease pain to a tolerable and manageable level, or eliminate the pain if at all possible. We always look to increase strength when possible and also increase a patient's sensation. It is very rare that in complex peripheral nerve surgery cases that the patient will experience a 100% reduction of pain. Risks of surgery and risks of peripheral nerve surgery include bleeding, worsening pain, numbness, complex regional pain syndrome, infection, loss of function, foot drop, nerve damage, need for additional surgeries, muscle weakness, DVT or deep vein thrombosis, poor or slow wound healing. Now, the patients that we operate on oftentimes will have many of these potential complications before we even start their surgical process. So, with peripheral nerve surgery, it's a little different than with a regular type of orthopedic or podiatric surgery. Postoperative expectations are very important. Essentially, the outcome of anyone's surgery is determined by a small area on the cortical surface of their brain. It is a neurosensory experience just like any other neurosensory experiences that patients will have. To that extent, your expectation will obviously determine your outcome. If you are unable to walk for more than 5 minutes without excruciating pain, and the pain of just ordinary daily activities of living are unable to be accomplished by you, and we perform some type of surgery that increases your ability but not completely eliminates your pain, then it could still be a very successful surgery if you have the right postoperative expectation. I've had patients that were quite frankly upset with me because they weren't able to stand or walk for 8 hours after their surgery, but failed to remember that prior to operating on them, they could stand for no more than 30 seconds. Now, swelling is always present in any lower extremity surgery. We don't really get too concerned with swelling unless there's some specific reason for it, such as infection, blood clot, those types of things. However, swelling is an expectation. It will happen in almost every case, and it is temporary. Discomfort is normal after any surgery. Usually, discomfort can be alleviated by elevation and decreasing the amount of activity that you are undergoing at that particular time after your surgery. We recommend limited walking, and sometimes we'll need to keep you free from weight bearing. Those are almost always temporary. Swelling can last sometimes for up to 6 to 12 months, but that's really a normal postoperative expectation and not a complication. Scars will develop anytime an incision is made. Some people will form a keloid scar. Even keloid formers will sometimes heal normally in certain areas and abnormally in other areas, depending on the surgical site. You may also have a small bulge at the surgery site because many times when we decompress a nerve, we have released a fascial compartment, and this allows the muscle to be a little bit more prominent. Usually this trade-off is very good because the patient's had significant pain, and some small cosmetic defects are really of little concern at that time. Virtually all peripheral nerve surgery is elective. This means that you, the patient, must decide if the benefits of surgery outweigh the risks of planned procedures that we have outlined for you. Because all peripheral nerve surgery is elective, we can and often do implement some conservative treatments. However, you should note that in patients with a compressed or pinched nerve, sometimes conservative treatments may actually decrease the potential outcome because they allow more nerve damage to occur while masking symptoms. However, in other situations, some of these things may be very beneficial, and we have probably already tried them with you, and they can, in some cases, work very well. What is an informed consent? Well, by definition, an informed consent means that you, as a patient, have been educated and understand what is going to take place before, during, and after the surgery, which is planned, and are aware of the potential risks of surgery. Remember, realistic expectations by the patient increase the success of the surgery. An informed consent also means that you understand that there may be alternatives to having the planned procedures. Alternatives to not having a peripheral nerve surgery or other surgery that we have planned for you may be doing nothing and learning to live with the present condition, perhaps desensitization, deep scar tissue massage, psychological or psychiatric consultation, pharmacological treatments like using drugs such as Lyrica, Neurontin, Cymbalta, Zoloft, Dizipramine, etc. Many times we will also, in conjunction with our planned treatments, have referred you to a pain management specialist or a sleep specialist. We do recommend that if you are on a medication like Lyrica or Neurontin, that you continue that medication throughout your perioperative process. Now,
peripheral nerve surgery can generally be divided into two types of surgery: decompression or neurolysis techniques, and denervation, which means removal or destruction of the nerve.
Would be decompression, which is also called neurolysis. The other category is denervation, which means we remove or perform some type of destruction process to the peripheral nerve itself.
There are usually greater risks involved with denervation or procedures that involve the removal or destruction of the nerve
after the surgery. The denervation or removal of a nerve have greater risks associated with that. Denervation really means to remove or interrupt the function of a peripheral nerve by either cutting it out, freezing it, sclerosing it, which means to cause scar tissue in it, or other means such as the use of radiofrequency ablation. We will frequently implement these types of procedures, but we have developed very strong preoperative criteria for patient selection, as well as some very refined techniques to increase the outcome with these procedures versus procedures that are just denervated without the use of these adjuvant therapies. We will talk specifically about these with you if you have this type of surgery performed. Decompression or neurolysis really means that your surgeon just frees the entrapped peripheral nerve from the surrounding tight tissues. There is no damage to the nerve. However, if the nerve is impinged, it could have internal damage. And when we are actually viewing that nerve during your surgery, we may need to do some work inside the nerve with microsurgical techniques.
Morton's entrapment, or more commonly called Morton's neuroma, is a peripheral nerve entrapment where the nerve is entrapped in the front part of the foot.
Injured, cut,
it is the opinion of AENS
process has had to occur
that decompression is a favorable treatment to excision or some type of procedure that requires injury to the peripheral nerve, such as ablation with radiofrequency or sclerosing injections.
And within the guidelines,
these types of denervation techniques may be needed for failed Morton's neuroma,
it should be primarily treated
treatment
by
of Morton's entrapment
and not resection.
In the opinion of AENS, should be oriented to decompression or neurolysis
in the majority of orthopedic and podiatric practices throughout the world. Some common examples of peripheral nerve decompression would include those that you see here below: Morton's entrapment, tarsal tunnel syndrome, common peroneal nerve, superficial peroneal nerve, deep peroneal nerve, medial calcaneal nerve. These are all common entrapments in the diabetic patient.
It is impossible to treat a peripheral nerve problem without having some effect to and from the brain. The central nervous system influences how you process external stimuli.
We've already talked about that itself. How you perceive stimuli is determined by the signal from the peripheral nerve, and it's being processed by the brain. But what goes on inside the brain, for example, if you are depressed or have anxiety, then that could change your neurosensory experience, and that may lead you to have a less than optimal outcome. It is possible for a patient with a peripheral nerve entrapment or injury to not have some effect in the central nervous system. So what this means is that once a nerve is hurt or entrapped, it does change the way neurotransmitters are formed in your brain, the way you experience things. It's also very common for patients to be depressed or anxious because they can no longer function in the capacity that they used to be able to do prior to their nerve injury. Pain can essentially be divided into two categories: acute pain and chronic pain. Patients who have chronic pain syndromes have a complex disorder which has associated central nervous system changes in addition to the injury to the peripheral nerve that has occurred. Your surgeon may also recommend psychiatric or psychological consultation and evaluation in order to treat any coexisting problems, and this can be a benefit to your overall outcome. Remember, it is virtually impossible to have a serious peripheral nerve injury without some changes in the brain's chemistry. Indications for denervation surgery: when should the nerve be taken out or its function interrupted? Essentially, this is very simple. When there is an amputation neuroma, which means that there has already been an injury to the nerve itself, then this type of surgery is indicated. The injured nerve is often called the pain generator. Nerves that are simply compressed or pinched are usually not subjected to treatment, which would be classified as denervation. In those cases, we will decompress the nerve or perform a neurolysis, with the understanding that sometimes we will have to come back with another surgical intervention to take the nerve and denervate it. Remember, there are greater risks associated with surgery that take out or interrupt the function of nerves. Collateral sprouting and nerve regeneration. When a nerve is cut, the part far away from the body makes a chemical called nerve growth factor. This signal works on other nerves in the area to increase growth to try to cover what is not present because the nerve has been removed. This is called collateral sprouting and can be the reason why the numbness goes away, but after a period of time, when you've had a nerve removed, the numbness will continue or may disappear altogether. Unlike nerves in the brain and the spine, peripheral nerves do regenerate after they have been decompressed, and this can give the patient some pain or hypersensitivity after surgery. But it's usually temporary and most often gone by the 12th week. Nerve denervation and permanent numbness. You will likely have a permanent numbness if we take out a nerve. You may get some feeling back, but you also may get some hypersensitivity in that area or other areas around it. Surgery is not finished at the time of the operation, and the patient must apply desensitization scar tissue massage while the nerves heal. This can take up to several months to achieve and can ultimately determine the overall success of the surgery itself. RSD stands for reflex sympathetic dystrophy. CRPS stands for chronic regional pain syndrome. The key symptom of RSD or CRPS is continuous, intense pain outside the proportion to the severity of the injury, which means that if you have a small injury and other areas get much worse, there may be CRPS present. CRPS most often affects one of the arms, legs, hands, or feet. The pain can spread to include the entire extremity. While there is still uncertainty in what causes this, many times it's due to a single pain generator in which a small nerve is hurt or entrapped, and this can be successfully treated by experienced peripheral nerve surgeons. If your surgeon has determined that your CRPS is due to an isolated injury or entrapment of a peripheral nerve, then it is safe to operate on that with the condition that the surgery has specific parameters surrounding how the patient is managed before, during, and after the surgery. Peripheral nerve decompression in patients with neuropathy, specifically diabetic peripheral neuropathy. We know that patients with diabetes have a greater susceptibility to develop a peripheral nerve entrapment. As a result, some of the symptoms may be due to the peripheral nerve entrapment, not their systemic metabolic disease. These are symptoms which can be improved with nerve decompression. Nerve decompression for diabetic peripheral neuropathy provides patients with symptomatic relief in approximately 80% of all cases. That is provided that the proper selection criteria is used in establishing who is a good patient and who is not. Most importantly, your surgeon is not, I repeat that, your surgeon is not operating on your neuropathic disease, but is simply decompressing a nerve in a patient with metabolic disease. That's a very important understanding. Please review your specific procedure videos that we have recommended, and if you do not understand or are confused by something, please contact us immediately prior to surgery. Our goal at U.S. Neuropathy Centers is to give patients the absolute best care and provide treatment and treatment plans that will lead to ultimate outcomes for patients, many who have been told that there's nothing more that can be done for them. Remember, our motto at U.S. Neuropathy Centers is positively changing lives every day, and we mean that.